The first one I wanted to talk about is cirrhosis because I think it ties in so well to the physiology we just talked about before. The pathogenesis of cirrhosis is that you get liver damage. That liver damage will activate our stellate cells. Those stellate cells will secrete TGF-beta, and that TGF-beta can potentially lead to fibrosis, and that fibrosis, if you have too much fibrosis, it'll turn into cirrhosis. So again, you have inflammation, stellate cells are activated, TGF-beta is released, that causes fibrosis, and if you have too much fibrosis, that'll in turn lead to cirrhosis. There are several causes of cirrhosis. This doesn't even probably doesn't even include a third of what can cause cirrhosis. We're going to go over most of these today, though. Alcohol, non-alcohol fatty liver disease, hepatitis, biliary disease, genetic syndromes, congestive liver disease that we talked about earlier. These can all cause cirrhosis. And then actually I'll go back to what we talked about earlier in our anatomy blood supply section. You can see that if our hepatic vein has a clot in it in Budd-Chiari syndrome, or if our right heart's just not working as well as it needs to, you're going to get congestion back in the liver, and that can cause cirrhosis. Here are all the symptoms of cirrhosis, and a lot of textbooks will just give it to you, just say, hey, here's all the symptoms, like just memorize this. I just wanted to include this just so you see it. And what I'm going to do is for every single section we talk about, you'll see one of these symptoms pop up, and I'll explain it in great detail just so you're not memorizing random stuff, and because I want it to all make sense to you. This is from our physiology section we just talked about. We talked about all the different functions that the liver has by way of production and metabolism. The nice thing is what I'm going to do for liver cirrhosis is I'm going to talk about what happens when each of these 10 things goes wrong. So now that we have liver dysfunction, we can assume that our production of those 5 compounds on the right is not going to be as efficient. And we could also assume that the metabolism of all 5 of these compounds on the, I think I said on the right here, on the left, the production of all these compounds on the left, if anything goes wrong there, we'll see what happens. And then we'll also see what happens if any of these compounds on the right cannot be appropriately metabolized. So let's start with production. I'm going to make a little table for all 5 compounds that I want you to know the liver is producing and what happens when things go wrong. So if bile's not getting produced, the thing I want you to remember first is fat malabsorption. And we've talked about this in the pancreas and in the small intestine lectures and in the gallbladder lecture, actually, that bile is important for fat digestion. And that works because lipids are amphipathic, which means they have a hydrophilic and a hydrophobic region. Here's our hydrophilic region. Here's our hydrophobic region. And I'll show what a fat globule will look like in your GI tract. We have our hydrophilic region kind of surrounding the barrier and encountering the watery environment, whereas all the hydrophobic chains are kind of hiding in the middle. And when lipases try to come in here, they really want this juicy thing in the middle, but they can't really get it as easily. The good thing is that bile is amphipathic, so bile can actually come in here and it'll convince these globules to kind of split up into several smaller globules because the bile is emulsifying it. And in this way, the pancreatic proteases have a much easier time with achieving more enzymatic breakdown and more surface area. And so that's what happens. The problem is in liver cirrhosis, if we're not producing any of this bile, then these globules don't get emulsified and they stay big and you get fat malabsorption. If the liver doesn't produce adequate proteins, there's many, many, many things that can go wrong. But 2 main symptoms that I'll talk about are peripheral edema and ascites. And in the physiology section, I talked about how there's 2 competing forces. We have our hydrostatic pressure that pushes fluid out of the intravascular space, and we have our oncotic pressure that helps pull fluid back into our blood vessels. So initially, usually the hydrostatic pressure will force fluid out into the interstitium, but because the hydrostatic pressure decreases and our proteins stay in and our oncotic pressure will increase relative to the hydrostatic pressure, the fluid will get pulled back in and everybody's happy. The problem is that in liver cirrhosis, we don't have enough albumin to start. And so we're losing a lot of that oncotic pressure. So the first thing that still happens is that the hydrostatic pressure will push that fluid out. But then as we get back down to the post-capillary venule, we have a very low oncotic pressure. And so there's no driving force to pull that fluid back in. And so that fluid will stay in the interstitium and you'll end up with edema. Ascites, I just want to point out ascites is extremely important, but I'm going to talk about it later when I talk about portal hypertension. So it's coming very soon. I just wanted to mention that I talk about it there instead. Coagulation factors. So because the liver is responsible for coagulation factors, there's a theoretical risk of bleeding. And I'll show you. So the PTT, we've talked about this in previous lectures, but the PTT measures this intrinsic pathway, so all of these guys here. And the mnemonic is you play table tennis inside, so that's how you remember PTT, whereas the PT measures the extrinsic pathway, and you play tennis outside, so that's a good way to remember that tennis is for extrinsic. Factor 7, as I mentioned before, has the shortest half-life, and so it's the one that's deranged first in liver disease, and that's why PT-INR is the most useful test of synthetic liver function. Thrombopoietin is important for liver production, and it shouldn't surprise you that thrombocytopenia would be a side effect of liver cirrhosis. So if you have no thrombopoietin, you don't get mature megakaryocytes and you don't get platelets. Glucose is not, if glucose is not actively produced or metabolized, you'll get hypoglycemia. So remember here from our liver function discussion that glucose can be glycogen can be converted into glucose as well as non-carbohydrate substances. And the liver is great at performing each of these processes. But if your liver's not working, you might not get so many monosaccharides floating through your bloodstream and you become hypoglycemic. Okay, so now let's talk about metabolism. So what goes wrong? If you can't metabolize certain products, what are going to be the end result? So if you can't metabolize drugs, it should be obvious that you can get drug toxicities. And this is common in liver disease. Maybe not common, but it's a known effect of liver disease. And that's why you have like dose reductions for people who have liver or kidney disease. The whole point of that is that you want to make sure that they're not going to have toxic levels of it based on the amount that they'll be able to excrete compared to a normal person. Ammonia is metabolized by the liver, and if you can't process ammonia correctly, you can get hepatic encephalopathy and asterixis. So recall from the physiology section we talked about earlier that if our liver's not working, we're going to have a buildup of ammonia, and that can result in hepatic encephalopathy. So hepatic encephalopathy is caused by decreased ammonia metabolism, and all that ammonia in your bloodstream can lead to neurologic dysfunction. This will present, as the name suggests, with encephalopathy or altered mental status. You'll also see something called asterixis. And what does asterixis looks like? You're going to have your patient put their arms out and point their fingers to the ceiling while keeping their arms spread out in front of them. And if you push, you can either push back on their arm, or sometimes you don't even have to do anything. If you just have them, stretch their arms out straight ahead with their fingers pointing the ceiling, you'll notice that their arms, their hands, and their wrists especially start doing this flapping tremor. So it'll start to do this flapping tremor like this. And that's indicative of, that's a physical exam maneuver that you can do to increase your clinical suspicion for hepatic encephalopathy. And this can get very severe. It's not like it just causes altered mental status. If you have severe hepatic encephalopathy, it can lead to coma or even death. So there's a few different things that can cause hepatic encephalopathy, most of which are related to liver cirrhosis. We just talked about why liver cirrhosis would cause that buildup. You can also have people who have some sort of baseline cirrhosis, but they're able to metabolize ammonia at some steady state. But if they have an acute GI bleed where additional ammonia is being released, or if they have an infection where the bacteria is releasing ammonia, or they have renal failure, all of these types of conditions can increase the amount of ammonia in your bloodstream and cause a problem. So in renal failure, what's happening here is that normally that urea gets excreted in the kidneys, but if your kidneys aren't working, you can get a buildup of urea, and that can actually backflow and cause a buildup of ammonia as well. One thing I want to mention, and we talked about this earlier, is that a TIPS procedure, which is often used, not often, but is occasionally used to treat significant portal hypertension, ascites, varices, things of that nature, a TIPS procedure can ultimately precipitate hepatic encephalopathy. So what's happening here is that if we have a lot of ammonia, normally it's going to go through our liver and be converted into urea, as we've talked about. In a TIPS procedure, which is done to alleviate portal hypertension here, what will happen is that this portal fluid can now drain directly into our hepatic vein, which will alleviate our portal hypertension and congestion. So that sounds great, but the problem with that is that now all this ammonia is also bypassing the liver and going straight into our hepatic vein. So instead of being converted into urea for excretion, we now have excess ammonia in our system, which can precipitate hepatic encephalopathy. There's two treatments I want you to know for hepatic encephalopathy, and those are lactulose and rifaximin. And I'm going to go over the mechanisms now. So lactulose, for lactulose, I want you to, we're going to talk a little bit about acids and bases. So ammonia, NH3 is a base. And what is a base versus an acid? So back to basics. So an acid is anything that can basically get rid of its hydrogen ion, and a base is anything that can accept the hydrogen ion. So there you go. Acids donate protons and bases accept them. And you can remember this by just remembering that that hydrogen ion always moves from point A, which is your acid, to point B, your base. So here we have an acid, it gives off its hydrogen, and in the case of ammonia, ammonia can grab that hydrogen and turn into ammonium. So it grabbed that proton, and now it's got a positive charge on it, as you can see. So in the case of ammonia versus ammonium, what I want you to realize is that this NH3, the ammonia form, can easily cross our GI tract barrier and enter our bloodstream. But this NH4 positive ammonium cation cannot easily cross our GI tract barrier because of this positive charge. So how do we use this physiologic discrepancy to benefit us in a patient with hepatic encephalopathy? Well, what we can do is we can give somebody lactulose, and lactulose will break down to a lot of lactic acids. And those acids naturally will release a ton of protons, and ammonia will see all those protons that are being released, and it'll start binding to them because it's a base. It'll bind to those proteins and create a bunch of ammonium cations. And fortunately for us, these ammonium cations cannot be absorbed by our GI tract, and they'll instead be excreted. So in this way, we're helping with our hepatic encephalopathy by not allowing any new ammonia into our system. Rifaximin works in a little bit of a different way. So rifaximin is an antibiotic, and normally we have bacteria in our GI tract that can produce ammonia. So here's our GI tract bugs, and they're producing ammonia, which can ultimately be absorbed into our bloodstream. Rifaximin is an antibiotic that can help kill some of these bacteria that are producing all that ammonia. So if we have rifaximin coming in, it'll take out some of those bacteria, which will ultimately decrease our ammonia in our GI tract and our bloodstream. Estrogen is important. The liver is an important organ to metabolize estrogen. And if that's dysfunctional, you're going to have excess estrogen in your system. And that'll show up in many different ways. You can get testicular atrophy. You can get gynecomastia, amenorrhea, spider angiomas, and palmar erythema. All of these are due to excessive estrogen levels. And something they love to test, what they'll do is they'll give you a picture like this. And somebody who sounds like they have liver cirrhosis, this is a spider angioma, or they'll give you somebody with red hands, reddening of the hands. And what they'll do is they'll say the the mechanism of action for this skin condition or this condition is most similar to the mechanism of what other symptom. And then they'll want you to pick, if I go back here, they'll show you a picture of like a spider angioma or pulmonary erythema, and they'll ask you that question. And they'll want you to pick like testicular atrophy or gynecomastia or amenorrhea. So I hope that makes sense. This is very commonly tested. They'll give you a spider angioma and they'll say, what's the problem with it? And or they'll say, what's driving this? And the answer would be estrogen. Or they'll say, what other symptom can be caused by this? So keep that in mind. Very, very high yield association that they love to test on. Okay, now we get to the fun part where we talk about portal vein fluid. So if you cannot adequately metabolize all that or process all that portal venous fluid that's coming into the liver, you're going to get portal hypertension, you're going to get Porto-Systemic Anastomoses, which I'll talk about in a little bit, and you'll get ascites. So here's where I want to delve deep into all of these contributors and talk about what goes on. So portal hypertension, as the name suggests, is increased portal venous system pressure. This can be caused by liver cirrhosis or vascular obstruction. So we'll talk in liver cirrhosis, if your liver's not working well at all, then you're just not going to be able to process all that portal fluid and it'll all back up. And so that's how you get portal venous congestion and hypertension. In vascular obstruction, even though the obstruction happens a little bit more, I guess, distal in the pathway, so right heart failure would be here, you'll have everything raised, including your portal vein. And in Budd-Chiari syndrome, you'll have a clot in your hepatic vein. And again, your portal vein will ultimately be congested and have higher pressures. And in portal vein thrombosis, same thing. If you have a thrombosis, you're going to have back pressure causing portal hypertension. So the complications of portal hypertension, you can get splenomegaly. And what's happening here is that as that portal vein fluid flows in the liver, if there's ever a problem with that flow, you'll get a backflow and it can actually reverse the flow and end up leading to congestive splenomegaly as well. This can also increase the risk of splenic vein thrombosis. So you can actually have a thrombosis in this vein. And I'm going to kind of quiz you right now as far as the most common cause of splenic vein thrombosis. We talked about it in the pancreas lecture. It's actually chronic pancreatitis. You can have a lot of inflammation in this region right here, can predispose people with chronic pancreatitis to splenic vein thrombosis. Some other complications, ascites is a big complication of portal hypertension, as well as porto-systemic anastomoses. I'm going to discuss these in, within the next couple minutes. So keep those in mind. Before I do that, though, I just want to talk about what a TIPS procedure is, because this is a treatment that can be occasionally used for people with really bad portal hypertension, symptomatic with ascites or varices. You want to at least consider a TIPS procedure, which is a transjugular intrahepatic portosystemic shunt. So what did I just say? What the heck is TIPS? So what it is if your liver's not working well, we're going to have a ton of portal fluid, and that can drain out and cause a bunch of problems, right? If we want to fix this, what we can do is instead of trying to go through this really, really crappy liver, maybe we can consider bypassing the liver, right? And so that's what a TIPS does. It actually is a shunt between your portal vein and your hepatic vein. So it's a portosystemic shunt, portosystemic shunt. And this seems great, right? Look at that. We just relieved our ascites and our edema. We have no more portal hypertension. Our risk of rupturing esophageal varices is less. Wonderful, right? Well, the problem with it is that it can precipitate hepatic encephalopathy. Remember, we just talked about how important the liver was in converting ammonia into urea for excretion. So we have our ammonia and it gets converted into urea. If we completely bypass the liver, then all that ammonia is just going to stay in our system. And so that can cause a really, really dangerous problem sometimes. So we've talked about portal hypertension. So now let's talk about some of the other sequelae of excessive portal vein fluid. So we're going to start talking about all of our porto-systemic anastomoses. So I've shown you this diagram so many times, you're probably sick of it, but we have our portal vein, drains into our liver, out the hepatic vein, and into our IVC. Keep in mind that in just a normal blood vessel that's not our portal system, we have our arteries. Those arteries go to arterioles and then capillaries. The capillaries drain into venules and then into veins. And then ultimately it'll go back into the SVC or IVC, depending on where you are. We'll notice how they both connect in the IVC. And so I'm just going to simplify this. We have our portal vein, ultimately goes into our IVC, and you have just a standard vein, ultimately also going into the IVC. What can happen is that if the portal vein becomes really enlarged and congested, there's a few areas in our body that are connected to our systemic circulation. So they actually have a connection naturally. And if this gets really, really big and has a lot of back pressure, it can actually cause higher pressures and congestion into our systemic circulation. So that's why it's called Porto-Systemic Anastomoses. So there's three places in our body that you need to understand have these anastomotic connections that are clinically relevant. We can get esophageal varices, which occur with a connection between our left gastric vein, which is part of our portal system, and our esophageal veins, which is part of our systemic circulation. You can also get something called caput medusae, which means like Medusa's head. And that's from our para-umbilical portal veins connecting with our epigastric veins. The last condition I want you to know about are anorectal varices, and that's where our superior rectal vein is has a connection and provides back pressure to our inferior or middle rectal veins. So let's talk about each of these three. The mnemonic that I think I saw in first aid, I want to give, this is not my mnemonic. It was, oh no, I wrote it down. UWorld, I guess, has this. Actually, no, I think it's first aid. I think I mistyped. Anyways, the mnemonic is you can get varices of the gut, butt, and caput. So here's your varices of the butt, your anorectal varices. You can also get it of the gut, your esophageal varices, and then you have caput. Let's start by talking about esophageal varices. So I'm going to use our chart that we just have. We have our left gastric vein. So imagine our left gastric vein, which you can see in the diagram here, is this vein here. Imagine this gets congested with because of portal hypertension. What can happen is that it actually has a little bit of a connection to the esophageal vein right here. And what's relevant about that is that our esophageal veins are not built to withstand high pressures. And the problem is that with these high pressures, it can actually rupture and cause a very brisk upper GI bleed that can be life-threatening. And here you can see an esophageal varix on the right. This slide was taken from the esophagus lecture where we talk about esophageal varices in great detail. And I just wanted to point out that the main pathogenesis involves portal hypertension, which is why we see it in this section. You can see that these varices can rupture because that esophageal vein is not built for that kind of pressure, and that can cause hematemesis. You can get bloody throw up. You can get bloody stools as well. Caput is a lower yield, but still relevant to know. Using our chart again, we can see here, we have our para-umbilical vein right here. So if this gets congested, you can see that it's connected to our epigastric veins right by our belly button. And so this can actually leak out, and you can see very profound. You'll be able to see these epigastric veins if you see somebody's stomach who has this, and it'll look like this. You can see it's called Medusa's head because it's got this very tortuous snake-like appearance of these engorged epigastric veins from our systemic circulation. Anorectal varices are also worth noting. You can see right here, here's our superior rectal vein draining into our portal system. And so if we have a backup of all that superior rectal vein, it can anastomose with our inferior rectal vein right here, and that can cause hemorrhoids. So you'll get some bleeding in this area. Now let's discuss ascites, which are a common side effect of portal hypertension. So ascites is just the fluid accumulation within your peritoneal cavity. And so what that would look like is if we have our picture here, that's just this whole cavity here. Just imagine that starting to get filled with peritoneal, with fluid essentially. This can be caused by a few different things. The most likely being portal hypertension. So most of the time, if you see ascites, it's portal hypertension. However, it can still be related to some pretty dangerous things. It can be related to malignancies, tuberculosis, and pancreatitis, among other things. And a question that's worth asking is, how do we tell? Is it portal hypertension? Is it a little bit more of a dangerous cause? We can use a lab test called the serum ascites albumin gradient, or the SAAG, to differentiate between portal hypertension and other causes. So how do you calculate a SAAG? So what you're going to do is you'll take a blood sample to get their serum albumin. You can see how that you need the serum albumin. You're going to first take a blood test, and then you're also going to do a paracentesis, which is where you just poke a needle into somebody's belly and drain out some of that acidic fluid. And you can also then have the albumin level tested of the ascites. So you're gonna collect the serum albumin and the ascites albumin, and then you'll minus them. So as an example, let's say your serum albumin's 4 and your ascites albumin's 2.5. That would give you a SAAG of 1.5. And how do you interpret these results? If it's ever 1.1 or above, then it's probably related to portal hypertension. And if it's less than 1.1, it's more likely to be another cause. Sometimes you'll forget, especially if you're studying late, like if you haven't looked at this in a while. So my mnemonic I like to use to remember, oh shoot, is it above 1.1 or below? I just remember that hypertension is always, we always think of hypertension as high blood pressure. So then that helps me remember, okay, high, the greater than value is going to correspond to the hypertension cause. So I just gave you a bunch of numbers and just basically told you to like remember that, but that's not helpful. So let's actually go through why is the SAAG greater than 1.1 in portal hypertension and less than 1.1 in other causes. So if we have our portal vein here and our peritoneum, if we have fluid in our portal vein, that's great, but then if it leaks out, now we have ascites. Remember, just like in any other blood vessel, our portal vein is going to be filled with some amount of proteins, mostly albumin. And in let's start by talking about portal hypertension. In portal hypertension, what's happening is that we have so much fluid within this limited space that you're going to just naturally just squeeze out some more fluid to the outside, just because there's so much hydrostatic pressure that some of that fluid will just inevitably escape into the peritoneal cavity. With that, just a very, very, very small amount of albumin will also escape, but nothing like the amount that we'll see in other conditions. And so then if we calculate the serum albumin here, let's just say our serum albumin is still 4, and let's say, a decent amount escapes into the acidic fluid, but not too much albumin. Then if we calculate the SAAG, it'd be something, for example, 4 minus 2, and that would still give us a SAAG of 2. And remember here that if anything greater than 1.1, likely related to portal hypertension. And it's because not too much albumin is escaping. It's a lot more of just the fluid escaping because of that strong hydrostatic force. What if there's another cause, though? So in another cause, let's just say that we don't necessarily have portal hypertension, but let's just say we have some malignancy or some infection like TB, or we have pancreatitis, and it's just damaging the entire wall of our epithelium. It's damaging our portal vein directly. So what happens here is that there's no hydrostatic pressure that's like preferentially throwing out a little bit of fluid and maybe, I mean, a lot of fluid and some albumin. In this case, it's anything goes. If your epithelia is damaged here, anything can escape into your peritoneal cavity, including albumin. So in this case, a lot more, you're going to have a higher number for your ascites albumin level. And so if you calculate the SAAG, you might get something like 0.5, which again, since that's less than 1.1 now, you're going to have a strong suspicion for these other causes of ascites instead of portal hypertension. So to treat ascites, you can give them paracentesis. A lot of people will come in every few weeks to just get a therapeutic paracentesis where they'll have a certain number of liters of fluid removed so that they can, breathe better and function better. You should often give them diuretics and restrict their diet, kind of like you do with heart failure as well. You can also give spironolactone. You'll notice a lot of people are on spironolactone as well as furosemide, very common. And like we talked about in the portal hypertension section, you can do a TIPS procedure. And this is, if your liver's not working, you'll get a backflow of fluid to get ascites. But if you have that shunt between the portal vein and the hepatic vein, then you won't have as much backflow and you'll reduce your ascites. But as we talked about before, remember that this can precipitate hepatic encephalopathy. So you don't use this in every patient with ascites. One important complication I want to discuss here is SBP, spontaneous bacterial peritonitis. And so what this is actually an infection of your acidic fluid. And it's usually caused by some bacteria that's already in your gut that migrate into the acidic fluid, such as E. coli or Klebsiella. And believe it or not, the majority of these cases are asymptomatic, but you can get fevers, chills, or abdominal pain. And so anytime a known person with liver cirrhosis comes in with a fever, chills, or abdominal pain, you need to have a high index of suspicion for SBP. And you can diagnose it by, like I said before, you can do a paracentesis where you just drain out a bunch of that fluid. But you can also do a diagnostic paracentesis where you take some of that fluid, send it out for lab cultures to see how many cells are growing in that culture. And a really, really high yield number that you need to remember for boards, definitely remember this, is that if you ever have an absolute neutrophil count of greater than 250 cells in your acidic fluid, that is diagnostic for SBP. Something, maybe this is more helpful on the wards. They'll give you, when you look at ascites fluid cytology, it doesn't give you the ANC directly. It'll give you like the total white cells. It'll be like, let's say it has 1,000 white cells, and then it'll say like 4% neutrophils. So then if you just looked at the white cell count, you might think, oh, nice, this person has SBP. I just diagnosed it. But in reality, only 4% of those white cells were actually neutrophils. So the absolute neutrophil count in my example would be what, 4% times 10, so 40. So you'd have an ANC of 40 in that specific example, and that would not meet diagnostic criteria for SBP. Again, they're not going to test you on that. That's kind of just like a little word pearl for you. Just keep that in mind. And you got to treat this with antibiotics, and you want to cover things that will basically make sure to cover your gut flora. So stuff like ceftriaxone. Oftentimes people will also add on like metronidazole in that case to cover for anaerobic infection too. Okay, so that covers portal venous fluid. Let's talk about what happens when bilirubin metabolism gets a little bit messed up. So some of the symptoms that you'll see in liver cirrhosis that have to do with inadequate bilirubin metabolism are hyperbilirubinemia, jaundice, and gallstones. So hyperbilirubinemia and jaundice should make sense. You can get, as we've seen so many times now, RBCs are broken down into U-bili. That U-bili gets conjugated, but if you don't have a good liver, you can easily have an elevated unconjugated bilirubin. At the same time, you can, if your liver is damaged in the more distal part of this process, you might still get bilirubin conjugation, but it can't get excreted. So then you'll get elevated conjugated bilirubin. So either one of these can still be true. You might have a conjugated, you might have unconjugated, you might have a mix, but you're going to see some sort of hyperbilirubinemia oftentimes in liver disease. And then just as a side note, anytime you have either conjugated or unconjugated bilirubin in your bloodstream, it'll give you jaundice. Gallstones are also possible in liver disease. This is from our hepatobiliary lecture where I talk extensively about gallstones. And I just want to remind you that bilirubin is a component of gallstones. And if you have elevated levels of bilirubin, or if you have the more insoluble subtype, like unconjugated bilirubin, inside of bile, you're more likely to get gallstones. There's two types of bilirubin gallstones that you had to remember. The black pigment stones are for hemolysis, and brown are for infections, and I have some good mnemonics there. And what I mentioned kind of in passing in the hepatobiliary lecture is that because you have impaired bilirubin conjugation, you could also get bilirubin gallstones. So if we go to the picture, if we have unconjugated bilirubin, the problem is that some of it won't get completely conjugated before it reaches the bile ducts because you have a little bit of liver disease. And my whole thing of how you get bilirubin gallstones is I tell you that you only get bilirubin gallstones when you have unconjugated. You have this like stone-like mass. And so that's kind of the mechanism by which people with liver cirrhosis are predisposed to gallstones, especially bilirubin gallstones in that case. One of the last things I want to talk about with cirrhosis is how it's diagnosed and how you stratify risk. The diagnosis, as with most things, the gold standard is a biopsy, but you can often just diagnose liver cirrhosis clinically. There's a few different scales that are used to stratify risk of people who have liver disease. There's the Child-Pugh class score and the MELD score. This wasn't emphasized on many of the resources. I know Boards and Beyond talked about it. I don't remember if many of the other resources talked about it. And I don't recall seeing it in step 1 or level 1, but it's been a while. I'm still going to tell you about them because that's what I do. I just give you way too much information. But I hope it can be useful for you, especially on wards. So the Child-Pugh risk stratifier uses 5 variables. And the nice thing about these is that these variables intuitively should make sense to you. We already know our bilirubin will be high in liver disease. Our albumin might be low. Our INR might increase because we don't have factor 7 working. We might have ascites and we might get encephalopathy. So it actually scores each of these from 1 to 3, and then you rate it. So 3 being the worst. And you calculate all 5 things up, and the higher score is the worst outcome. So a score of 5 to 6 is Child-Pugh class A, 7 to 9 is class B, and then 10 to 15 is class C, which is the worst of the Child-Pugh scores. The MELD score uses only 3 to 4 variables, so it still uses bilirubin and INR. It actually uses creatinine and sodium as, well, sodium sometimes as markers, and I'll talk a little bit about hepatorenal syndrome in a second to show why creatinine can sometimes be a useful marker of end-stage liver disease. The scores here are from 6 to 40, and a higher MELD score will indicate a higher estimated 3-month mortality. The treatment for liver cirrhosis, you usually give diuretics, and you have to treat the complications. And some of those complications we've already talked about. We've talked about pretty much everything I've talked about already is technically a complication, right? Like some sort of symptom of cirrhosis. We talked about ascites and SPP as well. You can get variceal hemorrhage from those esophageal varices, those anal rectal varices. You can get hepatocellular carcinoma. This is something I haven't really emphasized too much to you guys, but anytime you have chronic inflammation in your liver and you have cirrhosis, that's going to predispose you to HCC. And oftentimes we screen anybody who has liver cirrhosis should receive a screening liver ultrasound every 6 to 12 months to make sure there's no concerning masses. I talk about hepatocellular carcinoma coming up later in the condition section, but just keep that in mind. Very high yield cirrhosis and its association with HCC. The last complication I want to talk about is hepatorenal syndrome. This for sure will, I don't know, maybe not for sure. I'd be shocked if you got a hepatorenal syndrome question for step 1 or level 1, but I want to teach you it because I don't know. I just want to teach this, I guess. So hepatorenal syndrome, life-threatening kidney failure due to liver cirrhosis. So what's happening here? This is kind of my Cliff Notes version of it. Basically, when you have liver cirrhosis, you can't metabolize nitric oxide, and your liver also produces some nitric oxide. So you get way higher levels of nitric oxide in people with liver cirrhosis, and nitric oxide causes vasodilation. So your blood vessels get very dilated. And the problem with that is that if your blood vessels get very dilated, it actually pools blood in other regions of the body, and your kidneys will sense less blood flow to the kidneys. In addition to that, keep in mind that these people who have liver cirrhosis like this, they already have a lot of peripheral edema. So a lot of their fluid that we want to keep in their blood vessels, a lot of it's already escaping. So not only are we having lack of blood flow in our intravascular space initially, now we have this massive vasodilation. That's really going to restrict our kidneys' perception of how much blood flow it can get. Now, normally, if our kidneys are sensing low blood flow, let's say I'm like dehydrated or something, right? My kidneys will constrict. My kidneys will send stuff and they'll constrict all the blood vessels, and life will be maybe not great, but our kidneys can compensate. And so we're going to activate our renin and our renin angiotensin aldosterone system, and that'll cause renal vasoconstriction, just like this. There's a problem though. So normally, if this was my kidney, this would probably work. My kidneys would secrete these hormones, my vessels would constrict, and I'd have some compensatory blood flow to the kidneys until I hydrated myself, for instance. The problem with liver cirrhosis is that there's so much nitric oxide in our body causing this massive vasodilation that even if your RAS system is activated, you're still going to remain vasodilated because of that nitric oxide. And so what's going to happen is that your kidneys will keep constricting and constricting and constricting, just hoping that that's going to be a helpful factor to give up more blood flow temporarily. But the problem is over time, your kidneys are just going to constrict on themselves and they'll start to die off because they're just going to hypoperfuse. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.